All right, let's stay sitting. It's Friday afternoon. Okay, thank you for that introduction. Okay, so I know yesterday there was a question from Michael about, okay, this is great, and what are we going to do? How does this become real services? And I think it is really hard to follow the last panel and all of the information we heard, but we're going to do our best. So can go to the, I might need the pointer though to move my slides, I'm realizing. Thank you. See if this will, all right. So I also, I'm going to try to summarize what we've talked about in the last 2 days in about 5 minutes. And then I'm going to talk some about how thinking about different levels of translation and how we can use implementation science as well to translate some of the research into the clinical setting. And I'm going to do a little bit of intro before we hear from Dr. Vera around an example of a geriatric care model in the UK. So yesterday, I think we heard maybe that sleep was the unifying theory behind all of our aging problems from one of our keynote speakers. I think we've also heard maybe it's not sleep, but maybe it's exercise, maybe it's diet, but for sure it's non-pharmacologic, and that ties in with our deprescribing and polypharmacy, and that maybe it's smoking cessation, or how do we help people foster their own resilience and self-mastery, and how can we help people increase their social connections and decrease loneliness, and most importantly, how can we help people sustain that? We've also talked a lot about some mechanistic approaches. We had some abstracts as well as a session this morning on epigenetics. We've also had talks about geroscience. I think I'm thinking again a lot about CD4-CD8 ratios after some of the conversations today, as well as remembering how Peter Hunt told me 10 years ago about the KT pathway and how I should really look into that. And it's been really great to see some of those basic science, the knowledge really expand. I think my other big theme I was thinking of as we're trying to think about what's come up in this conference is how we can leverage new technologies. There's been some abstracts around machine learning models and some mention about AI, including in our polypharmacy thing today, the 38 minutes versus 34 seconds, which I'm still thinking about. But also, interestingly, one of the presentations yesterday was about how we can improve and study a low-tech technology like the lower magnet MRI, which might actually increase access. So it was really interesting to think about new technologies, but also how can we maybe leverage some of our older and existing technologies. And I think the other big theme today is all the early career and junior investigators in the room, and how can we foster that as well? How can we, as we're developing all these programs, whether you're doing basic science or clinical science, how are we putting the people with HIV at the forefront, and how are we bringing an equitable approach and really centering on health equity so that we know the healthcare systems in not just the US, but in many parts of the world are inequitable. So how can we center that to not then perpetuate inequity, and how can we really foster our partnerships with the community? So that was my attempt to pull out the themes from the last 2 days, as now I'm going through all my slides. I'm hitting the wrong button. So I'm going to now talk a little bit about then translational research and how we can eventually get to the point of taking some of these things, not just from bench to bedside, but into the community, and how we can also shape policy. So the great thing about this meeting is that there really are people doing, the basic science research and animal models, and thinking about long term down the road how that could impact human care. And I think we have to have all these components. We have to have investment into new science and new technologies that might lead to breakthroughs down the road, but we also have to take our existing what we know now and bring it into clinical practice. And so, you can think about the T0 to T4, but you can also look at this new figure I found, which really it's maybe not all one straight line, and it's really bringing in different disciplines and different perspectives all at one approach. And how do we develop new science? How can we importantly also disseminate that work? And again, like having the person with HIV in the center of all that, I think is really critical. So what is implementation science? Just if you're not as familiar. So one way is the study of methods that to increase the uptake of evidence-based interventions and bringing them into practice. And we think a lot about in intervention research, you're really looking at the efficacy, maybe the effectiveness, and implementation science is looking at how you're actually doing that work. And I just put up a comparison. I thought the University of Washington website was great at talking about different strategies and methods. And there are, of course, hybrid studies which look at both the effectiveness of an intervention, but also how it's implemented. There are, they range from looking primarily at the effectiveness of an intervention while gathering information and data on the implementation of that intervention. But there's also then the opposite, where you're actually really mostly looking at the implementation outcomes and a little bit less on the effectiveness, but how it was implemented. And there are so many theories, models, and frameworks that are part of implementation science. I had like a year of classes on different frameworks, so I'm not going to try to cover them in 5 minutes. But these are things like the CFER, the RE-AIM, PRISM, all kinds of theories and models. But really, those are very grounding so that you have a framework to not only think about how it's being implemented, but it helps other people then be able to replicate and think through their own implementation in a different setting. And I think a lot of times we've also heard some work at this conference around community-based research methods. And I think that is a big role of implementation science, and not just thinking how you can bring it from, bench to bedside, but how can we actually bring these things to really improve community health? And I think a lot of times we've heard at this conference too, it's not just quantitative measures. A lot of times it's qualitative and taking a mixed methods approach to really understand what worked or didn't work in the implementation of an intervention. And I wanted to give an example because we've talked a lot about reprieve yesterday, and it came up again today in polypharmacy. And I think reprieve, as we've talked about, is more for people at less or lower risk traditionally that might not have qualified for a statin. But this was data from 3 of the HIV clinics in San Francisco. And you can see these are people who qualified for a statin who were high risk. So this was before the reprieve results. These were just how many people who should have gotten a statin because they were high risk. 43%. And we had Dr. Priscilla Shu, an HIV cardiologist, in our clinic, and this was a cardiology fellow who took the initiative to look at this data. So even with embedded cardiologists in our HIV clinic, 43% who should have been on a statin, and we're not talking about reprieve criteria, we're talking about traditional ASCVD criteria, got a statin. And in the same study, actually, 80% of the people actually had an assessment of their cholesterol or had some degree of screening, but then the actual percent who went from screening to actual receipt of a treatment was half. So clearly there were some implementation challenges here. And so I think about, again, how are we going to bring results like reprieve into real world clinical settings where, as it was brought up this morning, pill burden, some people just don't want to take another pill, for example, or maybe how are they finding the priority of their pills? or if they can't tolerate a statin, like Jules mentioned, are there other options for them in their cholesterol? And I think, again, another theme from this meeting was, what about the people who are younger than 40, our life-term survivors? And as Dr. Siegler mentioned, what about the people over age 75? We have all these arbitrary cut points. So this is where implementation science can help. I wanted to just very briefly talk about other programs, because we're going to hear of an example, and we've heard of several throughout the conference. I think this slide was actually covered by on the Mount Sinai talk yesterday, and there are posters here around from Hive at BMC, from Mount Sinai Clinic, and then we heard about the chain study from Columbia, and on the slide includes Dr. Vera's clinic in the UK, and we've heard of some other examples from the UK as well. But this was in 2018, now we're in 2024. There's a few more, some have gone away, but there's still a kind of a handful of clinics. And this was shared yesterday too. Most are, some are combination clinics, some are, and I think those have shown where people are embedded in the clinic or co-located, there tends to be better outcomes. People feel comfortable coming to their HIV clinic for services. I just very briefly am going to say, so I'm not even going to go into the details of the Golden Compass program, which we've covered in past conferences here before, but was a multidisciplinary program at Word 86 where I was working before. And because of, I guess I'm a sandwich generation too, as was alluded to, I moved to Indianapolis to take care of my father with dementia. And so all the things that were shared in the last panel, it's also my full-time job to be a caregiver for him. And I think that is something we have to address more, as was mentioned in the last panel. But just from San Francisco to Indianapolis, there's about 16,000 people with HIV in San Francisco, about 14,000 in the whole state of Indiana. So it's a very different population. The other difference is from Ward 86, which was a comprehensive primary care and HIV care site altogether. In Indianapolis, most of the clinics are providing HIV specialty care, and patients need to get their own primary care. I was thinking of some of Marcia's comments, and that doesn't always work, having people go to their HIV clinic just for their HIV care and to access some of those ancillary wraparound services the Ryan White program provides, and then having them go to primary care to manage all their hypertension, diabetes, and everything else. And I think that line is really blurred as to who should be doing what, and something to figure out. So that's something I'm navigating now that I'm in a different kind of clinical landscape than was the model in San Francisco. And I think the other thing is thinking about rural parts of this country. So in 2015, Indiana was all the news in the US because of the outbreak in Scott County among people who use injection drugs. And they are still trying to develop their care systems. And one of the things we will be doing is making my services available through telehealth to other parts of Indiana, because there's no one else really doing that work. And so we're looking at how, with the state health department and others, we can partner to reach other services. And to point out that despite that outbreak in Scott County no longer allows syringe exchange services. So I think we have to think about the policies that are affecting our public health in this country and other places. I did want to talk about low and middle income countries as well, because I think there has been exciting work. I'm looking at some of my colleagues from Uganda, and this paper came out in 2024, highlighting some of the clinics in Zimbabwe, who we actually heard a talk about last year, sharing the Newlands Clinic and their comprehensive services and screenings that they're providing. Again, in that clinic, as well as in the Ampath Moy University program in Eldoret, of which I've had the privilege of hosting some of those colleagues in my clinic in Indianapolis, because Indiana University leads the AMPATH program. So there's been some great exchange we've had between Moy and Indiana. But if you look at both of these clinics, it's also 63% of their patients over 50 are women. And so I know in the last session, it was also mentioned about we need to understand more of the needs around aging women. But I think I also put some of the posters on here that were in our poster session here. There's a lot of exciting models that we're not even going to get a chance to talk about that are happening in sub-Saharan Africa and other parts of the world. And I think will be future topics for this conference. With that, I am right at time and we're going to turn it over.